Hi, I'm Dr. Mitchell Roslin. I'd really like to thank the ASMBS for allowing me to be part of this virtual program. Well, Sadi, or SIPS, or single anastomosis DS, has gotten a lot of attention recently. And I guess the subject that I've been asked to talk about is how did we get here? And it's really a pleasure, and I'm really excited that so many people are so interested, and this operation has gone from being highly criticized to mainstream. And there are a lot of reasons why. And I think that, as you can see from the people and the pictures that I have on this slide, the people who have been doing this have been doing bariatric surgery for a long time, all quite capable of doing procedures like gastric bypass, and have found that this operation offers their patients something additional. I'd like to also thank Gina Baldo, because if she didn't support our crazy idea, we never would have gotten this far at all, and really provided the support necessary for us to study this operation in a controlled clinical manner so that we could actually bring it to the mainstream. My disclosures are as follows. The only one that's relevant is the fact that I do receive a research grant from Medtronic, and I will be showing some of the continuous glucose monitoring data that we've generated from the devices that have been contributed. Well, we all know that sleeve gastrectomy has become the most popular bariatric procedure. But if the objective of bariatric surgery is to not be obese, and you can take a look at this slide, you can see that sleeve is a very effective operation for patients whose BMI is less than 45. In fact, if your BMI is less than 45, there's a 60% chance that you'll no longer be obese following this surgical procedure. However, if your BMI is more than 45, the odds go down to only 30%. And when you get to a BMI of 50, only 5% will not be obese. And that's with maximum weight loss. So if you look at most patients who are 5 years out from a sleeve gastrectomy, have a BMI that's more than 50, and have the normal degree of recidivism, a significant number of them will be morbidly obese, BMI greater than 40. So what happens when you add the intestinal component and you make it a stomach and intestinal operation is that instead of losing approximately 30% of your body weight, you lose approximately 40 to 50% of your body weight on average. In terms of BMI units, what we generally see is with sleeve gastrectomy approximately 13 to 14 BMI units. When you go into an operation such as Sadi, about 21 BMI units. So the real question is what is the absolutely best way that we can combine an operation that manipulates the stomach as well as the intestine? As a general rule, first thing to understand is that bariatric surgery is a controlled abnormality. So to some extent, we're asking a silly question, which is, what's the most physiologic way to make a controlled abnormality? Some very quick rules. Stomach gets weight off, intestine helps keep it off. Weight loss and metabolic improvement vary directly with the BP limb. You have a picture of the classic gastric bypass on this slide. And what you see is a very, very short biliopancreatic limb. And that begins to explain why there's not a significant difference between weight loss that occurs with a gastric bypass and a sleeve gastrectomy. In order to enhance weight loss, you have to prolong or elongate the biliopancreatic limb. Additionally, what we've seen with gastric bypass is that a significant, or most patients, not necessarily the ones that have severe neuroglycopenia, have hyperinsulinemic hypoglycemia. This is actually a CGM of a patient that actually has regained a significant amount of weight. You can see the high degree of glucose variation, especially in the evening. And this is really the extreme form neuroglycopenia that we see. This is a patient that was actually passing out that I had to reoperate on, that came to another center. See, there's a significant amount of glucose fluctuations. When your glucose goes down, What do you do is eat. So what happens in gastric bypass is that patients normalize their hemoglobin A1C, but they get there with great glucose variability. Now take a look at this slide from a single anastomosis DS or Sadi patient, and you can see that the line is virtually flat. By preserving the pyloric valve and altering the operation in this way, we have much less glucose variability. This is similar data that's been shown by Dr. Antonio Torres in Mexico. On the top, you have gastric bypass, and on the bottom, you have the single anastomosis DS with much less glucose variability. So essentially, we set out to come up with an operation that was more robust than gastric bypass and probably a little less toxic than the classic duodenal switch. We called it SIPS because we felt that DS just had this connotation of patients having malabsorption. Our concept, similar to Dr. Antonio Torres with some slight differences, was to do a sleeve gastrectomy slightly bigger than the average sleeve gastrectomy, and we mainly advocate doing it over a 40 to 44 French bougie. Dividing the duodenum, creating approximately a 3 centimeter duodenal cuff, and we decided to measure back from the ileocolic valve so that we'd have an afferent and efferent limb preserving 3 meters of intestine. Why 3 meters of intestine? The reason is we felt that 2 meters was too short, 250 may be reasonable, but there was going to be a considerable amount of mismeasurements. And compared to the Spanish version, our sleeve slightly smaller, intestinal length slightly longer. Idea, going to the mid-intestine. Several advantages of this approach: longer BP limb, more weight loss, preserving the pyloric valve, reduced glucose variability, lower diarrhea. And when we actually look at our results, what we see is that as opposed to the cutoff, or the majority of patients not being obese being at 45, more than half of our patients with a BMI of 50 to 55 will achieve a BMI less than 30 with very generally acceptable nutritional parameters. On average, patient losing 21 BMI units. More importantly, when you preserve the pylorus and you have that little bit of bicarbonate or mucus at the first portion, you don't see marginal ulcers, you don't see strictures. And this is a very important study done by Dan Cottam and many others that showed that the anastomotic complications with this approach were much less: ulcers, strictures. So in conclusion, in this brief presentation, I think increasing glucose variability with bypass increases oxidative stress and promotes eating when glucose naters. Post-pyloric reconstruction seems to allow for greater intestinal bypass with a lower chance of nutritional issues. Preservation of the pylorus allows for lasting control of restriction of solid foods, and combining a resection with post-pyloric reconstruction reduces chances of stricture and ulcer. I honestly believe that single anastomosis, while not perfect, with a post-pyloric approach is the best operation that we have, especially for patients that have a BMI greater than 45.